If we want to move to the next slide, that will be great. We are going to wait just another minute or so in case people are grabbing a bite to eat or a fresh cup of coffee to come and enjoy this information we get to hear today. We do want to take a moment to just acknowledge that the Minnesota Department of Health, or MDH, recognizes, values, and celebrates the vibrant and unique relationship between the 11 tribal nations and the state of Minnesota. MDH believes that the partnerships formed through a government-to-government relationship with the 11 tribal nations will effectively address health disparities and lead to better health outcomes for all of Minnesota. So thank you guys so much. We can go to our next slide. Wonderful. So before we officially get started and launch the State of Colorectal Cancer webinar, again, if you're just joining us, go ahead and put your name, your organization, and where you're located today, where you're joining us from across Minnesota in the chat feature. I'm going to turn it over to our friends and another team at the Department of Health. Go ahead.
Perfect. Thank you so much, Jen. My name is Brianna Langeway. I am the clinical systems specialist with our cancer screening quality improvement team, which sits in our larger comprehensive cancer control program at the Department of Health. Today, we're here to talk about what we like to call this webinar is the State of Colorectal Cancer in Minnesota. So thank you all for joining us again. And like Jen said, we'll have myself and some others from our Department of Health Comprehensive Cancer Program speak for a little bit. And then we'll pass it over to two of our clinical partners, Neighborhood Health Source and Lake Superior Community Health, to cover some of the various topics that we'll talk about today related to CRC. Next slide, please. All right, so this is just our list of presenters today. So we have I'll let our clinic partners introduce themselves when we get to their portion. But on our team, we have myself, Brianna, Michelle Brazier, she's our Cancer Screening Quality Improvement Director, Marie Tran, who's our Quality Improvement Coordinator, and as well as Chris Campbell, who is our evaluator for our team. So we'll kind of tag team our portion before we pass it along. Next slide, please. And we have the learning objectives here highlighted. I won't read through these just to save some time, of course, and they were included with the initial webinar invitation. But of course, we want you to take away, be able to talk a bit about the data and the burden of cancer, colorectal cancer in Minnesota, and then be able to talk about what that means for your clinic and what you can do for patients that you see. Next slide. All right, so just to start us out, this is a very timely webinar because March is National Colorectal Cancer Awareness Month. Highlighted on this slide, we just put a few of the many social media posts that we have highlighted for our Minnesota Cancer Alliance on Facebook and on Instagram. Some of these may look familiar as well because of course, they like the Go Blue for colorectal cancer is a statewide event as well as a national event with many organizations participating. And so just wanted to, of course, highlight the importance to remember that colorectal cancer is treatable and beatable, especially when it is caught early. The United States Preventative Services Task Force recommends regular colorectal cancer screenings for all Minnesotans, all Americans starting at age 45. Colonoscopies, stool tests, and other preventative practices can detect cancer early and averting the disease before it starts. And it's also recommended that all Americans should consult a doctor if they experience symptoms such as blood in their stool, a change in bowel activity, abdominal pain, bloating, persistent cramps, or unexplained weight loss. So, of course, want to recognize this awareness month along with, unfortunately, many cancer awareness months, but that is the topic for today. Next slide, please. And before I turn it over to Chris to talk about some of the data specific to Minnesota, we also wanted to highlight a national report that was published by the American Cancer Society just earlier this year that highlights colorectal cancer is now the leading cause of cancer death in men and the second in women under 50 years old. And again, this is nationally, but we will get into some of the state-specific rates and disparities related to CRC. But This, like I said, is a new report that the ACS just came out with. And as you can see, the 2024 estimates are trending in more deaths in younger populations across the country. So the increased prevalence of CRC and early detection and lowering the screening rate to 45 has really been elevated and shown in higher estimates for this 2024 year. So I'm going to turn it over to Chris on our team. He's our evaluator to talk about some of the state specific information. Next slide, please. Thank you.
Hi, my name is Chris Campbell, and I prepared a few charts for us to look at. The first of which I wanted to get a snapshot of how we're doing in this state, especially because COVID has happened. So it's influenced rates, and we're just starting to see some post-COVID effects because with colorectal cancer screening, if someone only gets screened once every 10 years with like a colonoscopy, the initial effects of COVID won't be seen because like the year of 2020, a lot of people were still on that fully screened status. And so what I prepared here was for the old guidelines for screening age, how did we do compared to the prior few years? So the outline is what we've seen pre-COVID. I'm considering 2020 to be pre-COVID because, as I said, the baked-in effects of COVID hadn't really struck yet. But we see an overall decrease in screening pretty substantially. For some racial ethnic groups, it wasn't as pronounced as others. Like it looks like American Indian and Hispanic weren't as influenced by COVID, but that is potentially due to margin of error. This is survey data, so it's not 100% accurate, but like seeing the decline overall is very real. Next slide, please. So we also wanted to look into what factors, other than race, have an influence on colorectal cancer screening. And especially because this is healthcare homes, we wanted to look at the impact of having a personal doctor. And it is very significant having a healthcare home or a personal doctor. So people who have a doctor that they see or they know the name of. I'm not sure exactly what the definition of a personal doctor is. It probably also depends on the person's idea of what a personal doctor is, because this is self-report. It's about 70%. So it's much higher than the 40% we see in people who don't categorize themselves as having a personal doctor. We see a similarly large effect of transportation. So if people don't have a reliable form of transportation, they're much less likely to be screened. We see perceived racism. So if people believe that they are being treated worse in a healthcare setting due to their race, they are less likely to be fully screened. I threw the error bars onto here because I did want to show that they are pretty wide, but there is definitely a difference between people who view themselves as being treated worse because of their race and people who view they're treated better because of their race. And finally, financial stress. This isn't incredibly surprising that people who view themselves as financially stressed are less likely to be fully screened. Next slide, please. I also wanted to show rates over time because new cancer rates over time, sorry. So this is actually taken from Minnesota Cancer Registry, MCRS. And so this isn't survey data. This is like counting the cases. So we can see in general that cases are trending down in Minnesota. We do see a tick up at the end there. Not sure exactly what's going on. I didn't include the mortality data, but it basically mirrors the incidence where we do see a trend downwards. Next slide, please. I also wanted to highlight the rates by race because there are very significant disparities in the Minnesota population. Most obviously, we see here American Indian have much higher rates than other racial ethnic groups. But you can also see that like the Black community, they may have higher rates than the white, but far and away, American Indians are much more likely to have to develop colorectal cancer than other racial groups. And again, I don't believe I included mortality. It shares the same sort of picture. Next slide. And I also wanted to, I believe this is the last slide, show the age groups because right now we are really seeing an uptick in colorectal cancer in younger folks. And like the rates right now are still low. Like it doesn't, this graph is kind of deceptive because it shows the dots for ages 50 plus and ages 20 to 49 getting close, but they're actually still really, really far apart in terms of incidence. But why we are concerned is we've seen an increase of about 50% in colorectal cancers in ages 20 to 49. And an increase in 50% of cancers, even if that rate is low, the baseline rate is low, is definitely concerning. We want to be seeing cancer rates going down like we've seen with the 50 plus group, not up. All right, so next slide. Okay, sorry, I have one more slide. I also used the survey data to see how people are getting their screening. And I was expecting to see that FIT kits or other fecal blood tests to be just generally trending up, especially during and post-COVID, because people are maybe less likely to go into the clinic to seek care if they're concerned about COVID. But we actually saw a decrease in people whose screening incorporated the fecal blood test. So that's not at all what I expected. So it seems like a slightly larger share of people who receive colorectal cancer. There's not an N that I have on hand. It's survey data, so there's and this is relatively large, having relatively large error on it. But just looking at the trend, previously I've been trending up steadily, and now it's ticked down a not insignificant amount. I can pull up an N if you give me a few days, but I won't be able to do it during this presentation, unfortunately. So the Minnesota Cancer Reporting System, MCRS, they're another state government agency. And while us at SAGE Programs, we help work with colorectal cancer screening, MCRS, they count the cancer cases and count the burden of cancer in the state. So mortality is another key indicator that they collect. They also have a bunch of information on this website for the risk factors of cancer, the current screening guidelines, and breakdowns that are even a little bit more in depth than what I've covered prior. So if you have any questions about colorectal cancer in Minnesota, I would definitely give that link a click. As I said before, I used some of the dashboard in this presentation already. They've got more than what I have presented. So yeah, that's it for me.
Great, thanks, Chris. And I think one advantage of that CRC dashboard is you can go to that and look at the county level and see what the incidence and mortality is specific to your county in Minnesota. And as Chris showed, we have a great reduction in colorectal cancer incidence and mortality in ages 50 and above since the 90s. And this is largely due to screening. Colorectal cancer screening can prevent cancer from developing. When colonoscopy was first discovered and first being more widely used, it was really effective in identifying polyps at an early stage before cancer develops. And during the colonoscopy procedure, those polyps are removed before they develop into cancer. So that's one reason we're seeing the cancer rates in the adults 50 plus going down. Unfortunately, we're seeing an increase in cancer incidence, in colorectal cancer incidence in younger populations that are not regularly getting screened. So more recently, 2 of our big guideline groups, the American Cancer Society and the United States Preventive Services Task Force, have both lowered their recommended age to start colorectal cancer screening for average risk adults down to 45. So while previously it was 50, the last couple of years, both of those groups have recommended starting at age 45, and that's for average risk patients. And that average risk patients are those that do not have a family history, do not have any symptoms of colorectal cancer, such as bleeding, abdominal pain, IBS, and any of those conditions that make them higher risk for colorectal cancer screening. So with recommendations going down to age 45, there are a few options. Next slide, please, for colorectal cancer screening. While colonoscopy has been long established as the gold standard, we also have some less invasive screening tests that are almost as accurate in screening for colorectal cancer. The least invasive are stool tests. These are tests that can be done, can be distributed at the clinic and done at home and brought back in and then sent out to a lab. They work by detecting blood in the stool. Most of them work, but there's a third one, which is the Cologuard test, which is a FIT DNA test, which works to detect blood or an altered DNA that's indicative of colorectal cancer. So those are great screening options. They unfortunately have to be done every year, and they're less likely to find a small polyp than a colonoscopy. The colonoscopy is the next test. Since it is so effective at identifying and removing polyps, it only needs to be done every 10 years. The provider, but unfortunately it is pretty invasive. You have to go out to a gastrointestinal facility, have it done, usually take a day off of work, but it does visualize the entire colon. So it's very good at detecting cancer and precancerous polyps. The flexible sigmoidoscopy is another commonly used test. I mean, I think it's less commonly used now. It's done every 5 years. The disadvantage of this test, it only looks at the lower third of the colon. And another test that is not frequently used is the CT scan of the colon. While it does look at the entire colon and needs to be done every 5 years, it's a fairly expensive test. And if there's an abnormal finding, it would need to be followed up with a colonoscopy. And just like the stool tests would, stool test, if they come back positive or abnormal, they do need to be followed up with a full colonoscopy. Next slide, please. So given that information, which test is the best test? I think that, you know, with the providers and the patients together need to weigh their individual preferences, the family history, and the genetic syndromes might make it more likely to use a colonoscopy as your initial screening. It's important to consider the resources available. The stool testing is much less expensive for patients that don't have insurance. And the most important thing is the likelihood that the tests will get done. I mean, if a patient is very reluctant to go and get a colonoscopy, then they might be a good candidate for having one of the stool tests. And I included a link to a clinician's reference tool, and it kind of describes all the stool-based tests and provides some detailed information on their sensitivity and specificity by brand. Next slide, please. And I think I hand it over to Marie at this point, and she's going to talk about what clinics can do to help increase their cancer screening rates.
Well, thank you, Michelle. So I'm Marie, and I'm the coordinator for the CSQI program here, working with the clinic directly. So what can we do at the clinic level to increase the colorectal cancer screening in the populations of the patient in the clinics? So you can see we have included in the slide here the link that you can actually access the CDC for a lot of resources. And there is a chain package that in the CDC program that you can all use right now to help your clinic enhance your capacity building for provider and staff, and also looking at screening policy, procedure, and practices at the clinical processes. And then how you can do a better job at follow-up and referral for patients who actually have done initial screening with the stool test and needed to follow up with a colonoscopy so they can complete their screening process. And that is the only way to detect cancer early. Next slide, please. So you have heard from Michelle and as well as Chris. Right now, cancer screening prevalence is going to lower age of populations. So the main thing right now is messaging to your patients. And the going right now, the message is get the patient to screen on time. And how do you do that? You don't have to really reinvent everything on your own. There are a lot of resources out there, and you can see there is a link on the slide that you can access a book, Tailoring Cancer Screening Messaging, that created by the American Cancer Society and the Roundtable. So how do you do that? The best thing to do is tailor your message that fit your audience. Not one message doesn't work for every population, so be mindful of that. Also address the barriers that each population is facing. A lot of time, it's easy to say, let go screening, but if you don't address the barrier, the social determinant of health barriers, nobody can do anything without that support. And also share your story. The reason I'm passionate about this work is my father died of this colon cancer. So I'm very passionate about it. And when I share my story, people are more likely to relate it. If it happened to me and you can see me, it can happen to other people around you or yourself. And also utilize a lot of different media approach to get your message out there. The different community respond differently to different kind of messages that out there. So be mindful of that. Next slide, please. And here's in this page right here, you can see a lot of resource link to a lot of information out there. Like I said, you don't have to invent anything on your own. Everything is already there, really made for us to use. Next slide, please. So a little bit about ourselves here, and you have heard that before. We are funded by the CDC program with colorectal cancer screening dollars. And using that dollars, we're working with some of the clinics that we identify that have lower screening rate. This doesn't apply to every clinic out there, only a certain clinic that we identify that have lower screening rate and the population that we needed to target and improve. So we work with those partners and get some funding for them to help them implement these system change approach to help bringing up those screening rate. And another way that you can all get involved is the Cancer Alliance, the Minnesota Cancer Alliance, Colon Cancer Network. There's a lot of resources going on out there. There are a lot of people working in colon cancer in the state of Minnesota. And the one area we're lacking is the primary care provider involving in the Colorectal Cancer Alliance to really bring the messages out and bring the message into the alliance from what you're hearing in the community and from your patients. So I encourage you to look into the cancer plan 2025 that we are working on half of it, and then we're also rewriting a new plan for 25-30, and we're asking everyone to get involved if you can. So check it out on the Cancer Plan website. Next slide. Okay, so that's it. That concludes our presentation on MDH, and I'm going to invite our partner, Neighborhood Health to present their work. we share the knowledge and what worked best. Alondra, are you around?
Yes. Hi, thank you, Mary. Hi, guys. We partnered with them. We are 4 clinics in North and Northeast Minneapolis, and then we have one in Grand Rapids. And then our population runs with 25% of um we are unsure, but there's an average of 44% of Latinos, and then 33% of African American, and 26% white. And then our aim in this project is to increase the colorectal cancer screening at a rate by 5% and organization wide, and also like to educate the community and to provide and facilitate this to the community because these preventative screenings are very important. So then a couple activities that we have done. So we have that we are embedding workflow for need for uninsured uninsured colonoscopies. When we give a fit kit, the community health workers and whoever gives these fit kits to the patients, we try to assure them an incentive of $10 for them to return the fit kit. And also, we are increased written and electronic communication. We have a person here in our team that sends text to these patients just to remind them yearly, or whoever has had an appointment and did not receive a fit kit to try to have them return to receive a fit kit for them. And then also the community health workers, they have a one-on-one with the patients, whoever comes in. Before they leave, they try to catch them to see if they receive a fit kit, explaining to them how it is, how it works, when can they return it, and then depending on how lab talk to them and stuff, they're trying to go over it so that they can receive more knowledge of it and then have a better return rate. And then we also talk about this at outreach events and educate the community in festival or other events. And then we just do each QR updates, which is the process of the fit kit. Some upcoming stuff. We are still trying to increase the written and electronic reminders, try to find a better efficient way to get more responses on this section. We are working on passing out hats and encouraging like that to encourage more returns, and that will be starting at one of our clinics, which is on the northeast side. It's the Central Clinic. And then just to promote more the incentives and no, and then promote the incentivizing and increasing the demand for adult physicals. And then this will, we could pull a list at our clinics. And then with this, we will increase the physicals, but also the fit kit returns. And then we would want to do this managed with the hats. That's where individuals can do their feces and then get a sample of it, just so they see this, that is like something important that they have to return for preventative causes for colorectal cancer. Next slide. Next slide is just a graph for colorectal cancer screenings. With this, this is it just shows that we have some variance in screenings and that it stays below the national average. So we still need a lot of focus on this. Next slide. And then just some successes. We are identifying subsets most people they need, which is the community out here that are lower class, and then we're setting up workflows to alert patients, identifying communication and opportunities. So we've gotten a little better on that section. Some challenges we have are trying to connect the non-patients, so people who we see at outreach events, and then also using in insurance incentives is it's a little very complicated. Sometimes people don't show a lot of interest for the incentive, that stuff, and then implementing the workflow across all clinics based on trying to have everyone at our clinics updated.
I am Peyton Likeball. I'm the population health specialist for Lake Superior Community Health Center. We can go ahead and go to the next slide. We have been working on colorectal cancer forever and just trying to make some improvements in that space. So right now we do a Go Blue Day during March. We just had ours last Friday up in Duluth. We also, and Superior, Wisconsin, we're on both sides. We also do a semi-annual data deep dive with our providers. So twice a year, I provide a dashboard that covers how every single provider is doing on colorectal cancer screenings. So they get to see how their rate is over time. They also get to see how many patients are in their population, how many they would need to reach our goals for what we've set for colorectal cancer. And then it's a really unique opportunity for the providers to have that internal discussion on what could be improved. So sometimes a provider is killing it, they're doing really good with colorectal cancer screening. So then that gives the opportunity for those other providers who might not be doing as well to kind of ask what those providers are doing to increase their rates. We do patient reminders. So we do remind patients when they're due for their colorectal cancer screening, but we also remind them when they have a fit kit that they need to return to us. So we give them about a month, and then after that, we're reminding them that they need to turn that in. And recently, we've started to do some more targeted follow-up on our patients who have a positive fit kit and then don't complete that colonoscopy. So we've been doing some calling to those patients to just kind of talk that through. We also offer referral follow-up for our patients. So if they're referred to get a colonoscopy anywhere, we do assist them in making sure they attended that appointment and can get scheduled with some of the larger health systems in our area. And then last year, we found that our fit kits freeze in the mail. So during the winter, we ask our patients to just drop them off at the clinic because they were getting sent to the lab and they were frozen and you couldn't use them anymore. And then we weren't getting that feedback. So we just kind of adjusted things for winter to make sure that that's not happening. We can go to the next slide. In the future, we are going to start offering Cologuard to our patients. We're pretty excited about this. It's a 3-year test compared to the fit kit, which is only good for a year. But we'll be offering it to our uninsured patients, and those patients that are at 200% of the federal poverty level will get the screening for free. And then up to 400% of the federal poverty level, they will get some assistance in affording that test. We're also offering it to our insured patients. In the past, it was pretty cumbersome to get that test ordered. So just a process improvement to make that a little easier for our insured patients as well. We're going to continue to do our patient reminders in the future. That has had some success for us. And then we'll also continue to do that quality improvement with our providers as well. So just checking in on what's going well and what's not. And I don't have this on the slide, but we are working with some Doctor of Nurse Practitioner students who this year are going to start surveying our patients to figure out their barriers to completing a colorectal cancer screening. So this will be very specific to colorectal cancer screenings, and it will allow us to kind of figure out where we might need to adjust our program offerings to make sure that our patients can complete that test. But that's what we're doing up in the Northland, and I think I'm going to be handing it back to Jen.
Great. Thank you guys all so much for sharing your perspectives and providing that information. Just a reminder to our participants, please put any questions that you have, whether it's for the MBH team or the team at Health Source or Neighborhood Health Source or Lake Superior Center. So whoever you'd like to ask, or if there's a general question you want for everyone, I do have a couple questions that have popped up, and this is listening to what was going on. You know, to the MDH team, with the changes in the current recommendation about those with low risk for colorectal cancer for screening to start at age 45, do you think that that may have impacted that 50% increase in that age group of the 20 to 49? And do you anticipate they'll now start lowering where it says 50 and above? Will they start lowering that threshold to 45 and above, or even kind of break out the 45 to 50? What do you guys think maybe behind that, or what do you anticipate in the future?
Yeah, I don't know, Chris, if you have any ideas, but yeah, I think the reason for lowering the screening recommendation age down to 45 was that we were seeing a lot of cancers diagnosed earlier. I also know that, when the screening rate was 50, there were a lot of people that really didn't get their first screening till 53, 54. So some of the messages that are coming out from the national groups and ACS are to start talking about it earlier. Don't wait till 45 to start talking about it. Just prepare them ahead of time so that you can get this first screening done at 45, and to be really, and anyone with any symptoms should be not treated with that average risk category. So anyone who is experiencing any symptoms such as blood in their stool, a change in their bowel activity, abdominal pain, bloating, cramps, unexplained weight loss, they should talk to their provider, and between their provider and them, they should decide whether they should go ahead and get screened, even if they're 25. But in terms of lowering the age again, I think it was, they just were lowered to 45, and it would probably take a lot of time and more evidence to lower it to 40.
There we go. Sorry. Thank you. I appreciate that. That would be me not unmuting myself. So we have a great question from Jane in our audience. What resources are available for patients who need a colonoscopy but don't have anyone to stay with them for the recommended time after the procedure or following the procedure? That's a great question.
That is a great question, and a lot of our partner clinics are starting to be creative about finding chaperones, because colonoscopy is a procedure where you usually need a chaperone to take you to the facility and stay there with you. So we've been creative about finding ways, but it's been kind of a clinic by clinic way to arrange for chaperones. And I think that's a good question, but there isn't really a great statewide solution to that. I think clinics are trying to figure that out one by one.
Yeah. One thing I wanted to add to that is this is a topic that we're hearing frequently. And when Marie was talking earlier about how to get involved, and we kind of have a gap in the Minnesota Cancer Alliance, that colon cancer network, it is a conversation that has come up with that group. I mean, that is a statewide kind of coalition of partners. And so I think that's something, if you are interested in getting involved in that, I think the clinic offering their perspective, if they've had a successful way of doing this, as Michelle had said, some of our partners have been exploring different ways of doing a chaperone program. And, I think that's something that hopefully kind of as a group collectively, we can come up with some resources that may be transferable statewide or identify facilities. I see the next question that might be able to provide some of those transportation opportunities to address that gap.
And yes, we don't have a statewide solution for addressing the transportation issue. We do work with a few clinics, mostly federally qualified health centers, and some clinics working with the American Indian population. We do have a taxi program, but that is available to our partner clinics. But even that hasn't really been utilized much because you do need a chaperone. So I think getting the chaperone kind of often addresses the transportation issue.
Good. Thank you
Yeah.
for addressing that as well. So one other question I actually had, Alondra, for in your clinic and your facility, I really appreciated how you guys are addressing and working to improve your screening rates, both internally with the use of community health workers and then also outside of your clinic walls during community events. And I noticed in one of your like positive things that have happened or the changes that have been made as you identified your subset of your greatest need or greatest risk patients. Can you tell us a little bit more about that, like what those groups look like or how you're addressing those things? Okay, well, we're working for Tessa to get unmuted. Let's see. I also had a question for Peyton and your team. I love that you're going to start. My question was going to be like, what are your most common barriers that you're facing? And I love that your organization is going to proactively screen for those to find out like what are the barriers. Can you tell us a little bit about what you've done so far for that screening tool or the approach you plan to take? And then Tessa, we're going to come right back to you, give you a chance to jump on. Yeah, so Peyton, tell us a little bit more about that.
So these students are going to develop a survey that'll go out to patients, ideally who haven't completed a colorectal cancer screening, just to kind of survey them on, is it transportation, cost, those kinds of things. We actually do survey all of our patients on social determinants of health, and so we have that information for all of our patients, but we really just want to figure out what's specific to colorectal cancer screening. So they'll get that survey, we'll tie it to some demographic information, and then we'll kind of go from there and analyze it. They're still in the beginning stages of this project, so we're still developing the survey and kind of going from there.
That is great. And you said those are students from?
College of St. Scholastica.
What a great collaboration. Keep us posted.
Yeah.
Okay, Tessa, thank you for joining us. I'll turn it back over to you to tell us a little bit more about that success that you've had with the subset population. Like, how did you figure that out? What does that look like?
Yeah, absolutely. And one of the things, certainly it's just a lot of work with the EMR, and we have a population health tool called Visolutions, which allows kind of just different ways of looking at the data and has been helpful to say like what's the helps us a little bit with creating panels for docs or providers to show them what their rates differentiated from everyone else's are, but also we can do more around like uninsured or insured or race and pieces like that. And then so one of the things we did, I'll say a couple of things, like, so we worked on figuring out how to pull our lists combined with insurance status, because in the beginning we couldn't pull insurance and who was behind on screening at the same time. And so then that made it difficult to do targeted messaging around FitKit versus Cologuard versus colonoscopy. And we will be able to do Cologuard, but we're still in the process of figuring it out. So that's one piece is working. We have two different kind of systems to pull reports. So working to figure that out and get more of our staff trained on how to pull the reports so we can segment out language, which has a lot to do with like, how we're going to outreach and who's going to call them, but also insurance status so that we're providing the right link and promoting the right thing. We really struggle with making sure we're not promoting something that's inaccessible to the patient. And so a lot of that was just figuring out the lists better. And then another piece that I'll just add on it is we're recognizing last year, maybe I think we thought, oh, the reality is like we're behind on all these screens and the physical takes care of a lot of that. And so if we can get people into the physical, then we definitely are getting the FitKit out the door. We're scheduling a mammogram and we're potentially doing the cervical cancer screening also. And so we're working on a project around promoting the FitKits, but promoting getting into a physical which has led to us, we have a community health worker who's in each clinic every day doing the screening for social determinants and responding to it. They are also then going through the day schedule and figuring out who's behind on a screening so that they can physically say to them like, hey, you need the screening, or can I sign you up for a physical? And so one of the things we realized when we tried to separate out the lists by some of the kind of demographic factors is that we were not gathering our race and language data very consistently, like only 65% or so of our patients. And so we did a retraining this winter and a restructuring of the registration forms so that we have to get that. So now you don't get to pick if you put that in, because we knew we had a lot more Spanish speakers and specifically Latino patients than we were getting on our demographics, and it didn't make sense. And so this, I think, will help us with that.
That is excellent. Thank you for sharing that. And thank you for I love how you adjusted your approach to focusing on the physicals and getting people in the door, recognizing where you could make a difference. So thank you for that. And I just want to, any more questions? I do know Tessa also put a little bit of information in the chat. You can check out addressing that chaperone issue that they've got, that they've offered to go with patients.
No one's ever said yes, but we do
Right.
offer, like we do say like, hey, we can go with you. And yeah, Marie was helpful with us setting up a process for getting colonoscopies for folks who are uninsured. So especially with them, we've been offering it, and no, nobody wants to yet, but we will keep offering.
Yeah, well, let us know, keep us posted if that suddenly becomes the thing that everyone is doing, is taking you up on the chaperone offer. Very good. Well, I don't see any other questions in the chat at this point in time. We do just want to thank our presenters again, thanking the MDH team and the team from Neighborhood Health Source and from Lake Superior Community Health Center, just for all the work that you're doing, but for taking time today to share that with us. And for those of you who have joined us today, thank you. There is a link Dorothy has put in the chat. Please click on that link and give us your feedback. Today's topic was in response to feedback that we had received requesting information about screening and chronic disease management, and this is one of those webinars that is a result. So please take a moment, let us know what's going well so we can continue to do that, and any ways that we can improve, let us know that as well so we can adjust and make it meaningful for you. If you want to reach out to us, please reach out to your practice improvement specialist, or you can reach our team via an email, check out our website, or call us directly if there's any way that we can assist you. But otherwise, thank you so much for joining us today. We hope you enjoy the rest of your afternoon and have a great week. Thank you.